again for another lecture in GI system, and today we will talk about the development of midgut. From the previous lecture that was about the development of the foregut, we mentioned the formation of the pharynx, esophagus, and the stomach, and you see here is the dilatation of the stomach and the duodenum, and the in which the liver also, there is a liver diverticulum or bud here also formed, plus to the which part of the duodenum, the up to the second part of the duodenum, just distal to the opening of the bile duct. Now that's the end of the foregut. Now after the foregut, you will find the midgut. So today we'll talk about this part of the gut tube that we call it the midgut, that extends from the duodenum exactly distal to the opening of the bile duct to the proximal 2/3 of transverse colon. That means the midgut started, if this is the opening of the bile duct, so from here distal to it, from the second part of the duodenum, then jejunum, then ileum, cecum, ascending colon, and the right 2/3 of transverse colon, or we call it the proximal 2/3 of transverse colon. So these parts represent the midgut. Now from there would be the hindgut. Anyway, so in the 5th week, the midgut, as you see here, is suspended to the posterior abdominal wall by short mesentery, as you see. Then what you see here also, that the midgut is connected with the yolk sac here by the what we call it Vitelline duct, or we call it sometime the Omphalocele duct. So this is the Vitelline duct that connects the midgut to the yolk sac. Now, for the as we talk about the development of the midgut, it's very simple. There are a couple of stages in which the midgut, through which the midgut developed. So first of all, the midgut would be herniated, physiological of course, herniated outside into the umbilical cord, then will be rotated. Once they're rotated, then they retracted back again inside the abdominal cavity, then fixed. That means it's very simple. First of all, happy to be herniated outside, then rotated. Then once they're rotated 90 degree, then retracted back. Once they retracted back, also they will during that process will also rotated also 180 degree, and then fixed. These are the steps of midgut development. Let us start with the first step, which is the physiological, we call physiological umbilical herniation. So look again to the midgut, in which at the 6th week, the midgut, as you see here, elongated to form like a U shape, like ventral U shape loop, in which at the mid of the apex of this U shape of the midgut that developed, there is a kind of a connection in which the Vitelline duct here from the tip of the U shape developed midgut connected to the yolk sac, right? So as a result of the rapid growing of the liver, kidneys, and because of the small the small cavity of the abdomen, still the abdominal cavity is a little bit small, and because of the rapid growing of the midgut, so the growing intestinal loop will push out into the umbilical cord. You see here, this is the loop of intestine, which is the of course I'm talking about the midgut. they are protruded outside, projected in the umbilical cord. This is the umbilical cord, as you see, they are projected outside. This is the physiological umbilical hernia. That means the loop herniated outside of the abdominal cavity, right? It is temporarily, right? Because of probably growing of the liver, kidneys, and the temporarily small abdominal cavity. That was about the 6th week. Now, as I mentioned, here is the loop of the midgut, in which, as you know from the previous lectures, that the midgut supplied by superior mesenteric artery. Look at the here's the primary intestinal loop, in which, of course, supplied by superior mesenteric artery. We know that the duodenum, which is originated from foregut and part from the midgut. So the part of the duodenum that originated or developed from foregut supplied by celiac artery, while the part of the duodenum that's supplied, of course, below the opening of the bile duct, that originates from the midgut supplied by superior mesenteric artery. Anyway, the elongation of the gut here with its mesentery form the primary intestinal loop. So this is the primary intestinal loop. That's, of course, I'm talking about the midgut. So the primary intestinal loop that you see here has two limbs. The first one, or superior one, which is the cephalic, and this one is the caudal. So you have one up and one down, cephalic and caudal limb of primary intestinal loop. And as I mentioned, the apex of this primary intestinal loop connected with the yolk sac through the Vitelline duct, or what we call it omphalocele duct. Now, okay, this is the primary intestinal loop. That's, of course, the midgut, right? So the cephalic limb, you have to know that roughly, let us say now, roughly, it will form the small intestine, right? Part from duodenum, jejunum, and most part of the ileum. While the caudal limb will form the large intestine, not all the large intestine, I mean the cecum with the appendix, ascending colon, and the right 2/3 of transverse colon. Okay, so this is the cephalic limb, form the distal part of duodenum, jejunum, and part of ileum, while the caudal limb forms the lower portion of the ileum, cecum, appendix, ascending colon, and the proximal 2/3 of transverse colon. So that was, you remember the first stage in the development of the midgut is the proliferation of the midgut to form the primary intestinal loop. That's because of rapid proliferation and because of the large size of the growing of the liver, kidneys, and because of the small cavity, abdominal cavity. So we mentioned in the first stage that there is a physiological herniation outside in the umbilical cord. That's great. So the second stage is the starting of the rotation scenario. That means this herniated intestinal loop in the umbilical cord, now they were rotated around the axis of the superior mesenteric artery. So this is the superior mesenteric artery. So of course the rotation of the midgut is counterclockwise, right? If this is the clock, right? So it's counterclockwise. That means the superior limb, or what we call it, the cephalic limb, will move to the right, and the caudal limb will move to the left. Look at it here. The cephalic limb will move like this to the right, and the caudal limb will move to the left 90 degree. Look at this map, right? 90 degrees. This is the result. This is the first rotation, the first 90 degrees rotation. Look, they were above each other. Now the cephalic limb will be here now, and this one, the caudal limb, will be here. So because we moved 90 degrees, that means the cephalic limb will be to the right here, and the caudal limb will be here to the left, right? Okay. You know that the cranial limb, again, let me remind you, will proliferate, of course, and grow. The cranial limb grows rapidly and forms small intestinal loops, while the caudal limb undergoes very little change, except for the development, as you see here, of the cecal swelling that will give the cecum and appendix. So the idea that the proximal loop grows, the cranial, say, or the cephalic limb, sorry, the cranial limb or cephalic limb grows rapidly, right? To form, of course, you know, jejunum and ileum. Always remember about 6 meters. Anyway, so okay, now once they projected into the umbilical cord, they rotated 90 degrees. Then what's the next step? The next step that the limbs will be again retracted back to the abdomen. They have to return back to the abdominal cavity, but during that process of retraction, and after also they retracted inside the abdominal cavity, they were rotated 2 times, right? It's that means 90 and 90, that means 180 degrees. Look at it here. So this is the cranial limb, 90 degree at the first, now it becomes here, right? Then from there, once you know the process of retraction, so while they are retracted, they also rotated during that process. Look at the arrow again, counterclockwise, عقارب الساعة. So now it becomes down here. Then also, and after they retracted inside the abdomen, also they retract again. So by the end, you completed totally 270 degrees. Okay, so yes, I think you noticed that I said that the midgut that were herniated, they were retracted. That means the second process will be, after rotation, is the retraction of the herniated loops from the umbilical cord during the 8th, of course, week. This is called reduction of midgut hernia. Reduction of midgut hernia. So we'll keep in mind that if you look here, my friends, you would notice, let me erase these things. Maybe you noticed that the first thing to be retracted, the first thing is the part of the proximal part of the jejunum, right? You know, there's a stomach, duodenum, and jejunum. So the first part that was retracted first was this part, the proximal part of the jejunum. Then look, the last thing that will be retracted is the cecal butt. That will be the cecum and, of course, the appendix, right? So this is what I mentioned. So look at the loops of the jejunum and ileum. They retracted first. They then took the central part of the abdominal cavity. Then the last thing to be retracted is the cecum or cecal butt that gives, of course, cecum and appendix. If you notice, yes, here is just the same figures I showed you, but they are maximized. And um, here is like after the complete rotation, 27 degrees, and still the cecum. Look, the cecum still at this is the liver, right? Now the cecum located just under the under the liver, right? This is the cecum, and this is the liver, and this is the right upper guanal below, like right lobe of the liver. Anyway, now what will happen? Look at the arrow. The cecum will move, of course, to the last destination, where is, normally located at the right lower iliac fossa. So it moves down, taking with it the colon. So during that journey, look, from the cecal bud here, there is a kind of a small diverticulum grows from there, which is that would be later the appendix that grows as a narrow diverticulum from the distal end of the cecal bud. Now, because the appendix formed during the descent of the cecum and ascending colon, so the position of it is like varied. Sometimes it's behind the cecum, sometimes it's behind the colon. That's why it's called retrocecal, that means behind the cecum, or retrocolic, behind the ascending colon, and sometimes hanging down in the pelvis, called pelvic appendix. Yes, this is what I mentioned. So this will be covered, of course, in the lecture of the abdominal or of the appendix later, but I would like to say just for now that the most common location of the appendix is retrocecal, and the or retrocolic, right? Retrocecal or retrocolic. This is the most common positions of the appendix, right? Of course, with the sometime this is the most common one, retrocecal or retrocolic, behind the cecum or the lower ascending colon, and also sometimes hang down in the pelvic. We call it pelvic pelvic appendix. Also, it's very common. So the first and second positions are the most common sites. We'll talk about that later when we talk about the appendix. So yes, we know that there is no mesentery in the thorax, but there is mesentery in the abdomen, and we know that the stomach connected with dorsal mesogastrium with the abdominal wall. Also, the first part of the duodenum also. It has also mesentery, plus the small intestine, as you see here. Also, they have mesentery. We call them mesentery proper, and the ascending and descending colon, they fused with the posterior abdominal wall. And so you have to forget the story of mesentery for both them, but still the transverse colon has a mesentery, which is that way we call it transverse mesocolon, and the sigmoid still has a freedom to move and has a mesentery. We call it sigmoid mesocolon. So we call it in relation to the organ that connected to it, right? For example, mesogastrium, because it's a mesentery that connects the stomach, gastrium, I mean. And look at the first figure here. We removed the greater omentum. We cut it here to see and have a look to the other parts of the mesentery. So you have the mesentery proper that connects mainly the jejunum and ileum, and of course we used to have the mesentery ascending and descending column, but they fuse with the posterior abdominal wall. So you have to differentiate between the gray color, in which it shows that these structures related to it connected to the posterior abdominal wall, right? And to the brown color here, in which it shows the mesentery. For example, transverse mesocolon that connects the posterior abdominal wall to the transverse colon, sigmoid mesocolon, mesentery proper, and distally parts from the rectum. So these structures, because today we are talking about the midgut, that means from the just in the duodenum below the opening of bile ducts, jejunum, ileum, cecum, appendix, and ascending colon until the right 2/3 of the transverse colon, because we talk about the midgut. So the mesentery, look, the mesentery of the jejunal loop is at first continuous with that of the ascending colon, but the mesentery of ascending colon fuses with the posterior abdominal wall. Then the mesentery of small intestine becomes like a fan shape, as you see here, and it acquires the oblique line from the say duodenojejunal here, duodenojejunal junction to the ileocecal junction. So look here at the arrows, because as I mentioned, the intestines will be fixed. So this is the ascending colon, and this is the descending colon on the left, and of course this is a part of small intestine, the jejunum. Look at the fusion, the arrows that shows the fusion of the ascending colon and the descending colon, as I mentioned earlier, with the posterior abdominal wall. That means the mesentery will be here disappeared, and they are fused with the posterior abdominal wall to get this view. But still, the small intestine, they have mesentery and the freedom to move. This is, of course, the intestine before or prior to fixation. Look at the stomach that connected to posterior abdominal wall by mesogastrium, and of course, anteriorly it has a greater omentum, which is double layer of peritoneum, unfused, but with time, the greater omentum will be fused and obliterated. Plus, look at the transverse colon that fuses with the greater omentum here, and it makes like a pressure on the pancreas and duodenum, pushing them back to the retroperitoneal structure. That means behind the peritoneum, right? So look at the fusion of the transverse colon. That's why you have the lesser sac here, and you have the stomach connected to transverse colon like this by the greater omentum, right? Interesting part of the embryology of the midgut, which is the midgut anomalies. So let us start with the abnormalities of the mesenteries. We know that the ascending colon lost its mesentery and it fuses with the posterior abdominal wall. That means there is no space behind it and it's fixed to the posterior abdominal wall. So sometimes the failure of the ascending portion of the colon, that means failure of the ascending colon to attach to the posterior abdominal wall, creates a kind of mobile part there. That means you have a mobile colon in which giving the colon the mobility, that means it increases the chance to twist on itself, as you see here, something called volvulus. It can be volvulus of the cecum and also volvulus of the colon, and in which also it gives a chance for the small intestine to be entrapped behind it, something called retro, that means behind, retrocolic hernia. That means part of small intestine herniated behind the ascending colon and cecum there. Okay, this is the abnormality of mesenteries. But also, we know that during the development of the midgut, we get abnormality of the body wall, anterior abdominal wall itself. The first one, which is common called Omphalocele. Omphalocele, that means uh, you remember this word omphalo, vitelline. It's compared to, it's equal to vitelline, right? Vitelline duct, or if you remember, omphalonteric duct. Anyway, Omphalocele, that means there is a sac outside in the umbilical cord. So you see here, this is the umbilical cord, this is anterior abdominal wall. So there is abdominal contents, can be small intestine, can be jejunum, ileum, liver, or so. So the abdominal viscera or contents herniated, still herniated outside in the proximal part of the umbilical cord that close to the abdominal wall, as you see here. So this is the umbilical cord, and this is the proximal part of umbilical cord. However, it contains the abdominal contents. Why this happened? This is because of the failure of the intestinal primary intestinal loop to return to the abdominal cavity, to retract it in the abdominal cavity. You think you remember from the lecture that the first process in the formation or development of the midgut is that the primary intestinal loop herniated outside into umbilical cord, but at the 6th to 10th week, the loops should be returned back to the abdominal cavity. The failure of the retraction or return, the failure of retraction of the intestinal loop and contents into the abdominal cavity leads to omphalocele. Okay, what else we have? An example of abnormality of the body wall other than the omphalocele. We have gastroschisis. Yes, gastro, when you read it, gastro, it means like stomach, but indeed this is misnomer. Misnomer, that means mistake. Misnomer or not the correct way to call. So misnomer because the split not in the stomach, the split indeed in the anterior abdominal wall. But anyway, gastroschisis, again, there's a protrusion of the abdominal content through the body wall, as you see here and as you see here and here. They are not covered by amnion or peritoneum, because we know if they are covered by amnion or peritoneum, we call them omphalocele. But if they are not covered, we call them gastroschisis, without any cover or skin or whatever, or amnion or peritoneum. So the bowel can be damaged by exposure to amniotic fluid there, right? So why this happened? This happened also again because of abnormal closure of the body wall around the connecting stalk. Usually occurs like to the lateral to the umbilicus to the right. So this is the gastroschisis. Also, we have the umbilical hernia. Sometimes I would say it's common, but here the intestines in general retains to the you see they are inside the abdominal cavity at the 10th week, but there is a kind of small herniation through the imperfectly closed umbilicus. That means the umbilicus is not perfectly closed. So in this case, you can see a small part of small intestine or greater omentum, and they are covered by skin and subcutaneous tissue, in which usually in the newborn you can notice that, and it's protruded outside when they start to cry or straining or coughing, right? So usually you have to wait until like the age of 3 to 5 years and fixed by surgery most of the time. Okay, away from the abnormalities of the abdominal wall, and now I would shift to the abnormality of Vitelline duct itself. So it's between 2 to 4%. look at this here example, the persistence of a small portion. Here is the anterior abdominal wall. This is the umbilicus. The yolk sac was here, so there was a connection through the vitelline duct, so it should be obliterated. But if there is a small persistent small portion of vitelline duct formed, it creates a kind of outpouching of the ileum. This is your ileum, for example, and there is here outpouching. We call it Meckel's diverticulum or ileal diverticulum, right? This is the Meckel's diverticulum. Sometime, yeah, the vitelline duct obliterated from both sides behind the umbilicus here and the ileum, but still there is a small cyst there. Sometimes it is asymptomatic. There is no symptoms except if it's inflamed for a reason or another. Sometimes this is, we call it vitelline cyst or Enterocystoma. Also, the most severe case of vitelline duct abnormality is the vitelline fistula. That means the contents in the ileum can open outside through umbilicus, outside the abdominal cavity and wall, and we call it vitelline fistula. So you have Meckel's diverticulum, like this one. You have vitelline cyst, or you have the most severe one, which is the vitelline fistula. Okay. Again, we talked about the abnormality of the midgut. Sometimes the problem or the defect in the rotation. So again, malrotation of the intestinal loop can result, as I said at the beginning, into volvulus of the, can be small intestine, large intestine, and this will comprise the blood supply and lead to gangrene and necrosis of that part of intestine. Also, if the rotation, we know that normally the midgut should be rotated to 70 degrees, but if the rotation is just for 90 degrees, that means only if there is rotation just 90 degrees, that means the colon is on the left side, right? As you see here, because we know that we have caudal and we have rostral and we have caudal lobes, and when they are rotated, the caudal lobes will give the mostly large intestine. I'm talking about the midgut, that means cecum, ascending colon, and the right 2/3 of transverse colon. That means still it is on the left, right? As in this case, look, the cecum, ascending colon, and transverse colon and so forth, it's located on the left, not on the right, which is incorrect. In this case, you have left side colon, left side colon. Okay, now if that was the, of course, I've talked about the rotation of just 90 degrees counterclockwise, but if the rotation occurs 90 degrees clockwise, that means reversed rotation, what will happen, what you will get is that the transverse colon is located behind the duodenum, right? Behind the duodenum. So the last abnormality of the development of the midgut is the atresia and stenosis. Atresia, here's like you see the 1, 2, 3, 4, and this is the most common cases of atresia of the midgut intestine here, and it occurs usually in the duodenum, fewest in the colon, and similar to that in jejunum and ileum. And the atresia of the duodenum, just say here, stomach, duodenum. So if there is atresia of the duodenum, usually it occurs because of lack of recanalization, because there is endothelial cells here full, then it starts to degenerate and recanalize it. But the atresia in the let us say distal part, small intestine, um, it's usually, or distal to the, of course, to the duodenum, usually it occurs because of a vascular accident, results sometimes from the twisting of or malrotation of the small intestine that leads to compromised and decreased or sometimes obliterated of blood flow, and then it leads to necrosis, right? This is of course the last thing about the abnormality of the midgut. Thank you, and hope you find value in it. Thanks.